Welcome back to CLOT Conversations, the podcast where we explore the latest evidence and innovations shaping thrombosis care. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm joined once again by my co-host, Dr. Jameel Abdulrehman. Dr. Maha Othman is off today. And thank you for being with us today. In this episode, we're focusing on a clinically important and often challenging question. How should we optimally anticoagulate obese patients with cancer-associated thrombosis? To help us explore the new evidence from a multicenter prospective cohort study on the use of weight-adjusted dalteparin in patients over 90 kilo with acute cancer-associated venous thromboembolism, or the WAVE study, recently published in the American Journal of Hematology. We're honored to be joined by two experts and co-authors of the study. First, Dr. Tzu-Fei Wang is a hematologist and an associate professor in the Division of Hematology, Department of Medicine at the University of Ottawa and the Ottawa Hospital, and a scientist at the Ottawa Hospital Research Institute. She holds a Tier 2 clinical research chair on cancer and thromboembolism from the University of Ottawa. Her main areas of interest include clinical research for the optimal prevention and treatment strategies for patients with cancer-associated thrombosis, drug-drug interactions with anticoagulants, and obesity-related thromboembolism. She currently is chair of the ISTH, International Society on Thrombosis and Hemostasis, Live Courses Subcommittee of the Education Committee. And Dr. Grégoire Le Gal, professor of medicine at the University of Ottawa and lead of the thrombosis program at the Ottawa Hospital, and senior scientist and program director at the Ottawa Hospital Research Institute. His research focuses on diagnosis and management of venous thromboembolism. He has published more than 500 peer-reviewed articles, is co-director of CanVector, and is the 2024 recipient of the Chrétien Researcher of the Year Award. We're delighted to have both of you with us. Let's get started. So to begin, can you tell us what the motivation is to conduct this study?
Hi, everyone. Well, thank you for having us. Happy to start on that one. I'm Gregoire Le Gal. Yeah, so I think the idea came because when you use low molecular weight heparin, often you use prefilled syringes, and the way the clinical studies developing low molecular weight heparin were performed made that at the end of the day, the highest possible dose, or the highest the prefilled syringe would correspond to a body weight of 90 or 100 kilograms. And the product monograph for these molecules usually recommend not to exceed these doses. In other words, recommend to cap the dose at a dose that you would use for a patient 100 kilo or so. Not sure why exactly. Likely because again that these were the only doses that were tested based on the population of patients that were available at the time these studies were conducted. But with the increasing rate of obesity in current days, right? Because these were like 40 years ago, maybe. We often have patients whose weight exceeds 100 kilo for sure, and so the question came up as to whether we should really cap there, even for a patient weighing 120, 140, or 160 kilo, which does not seem to make that much sense, given that for body weights ranging from between 50 and 100, we constantly adjust to the patient's body weight. So truly, the questions behind the study was, okay, should we stick to what the product monograph says, which is not to exceed the dose you would give to a patient weighing 90 kilo, or should we continue to adjust to the patient's body weight regardless of that body weight?
Okay, great. So you conducted a single-arm, multicenter prospective cohort study in patients over 90 kilogram with cancer and acute VTE who were treated with therapeutic dose dalteparin, either at 200 units per kilogram daily or 100 unigrams per kilogram BID for at least 30 days. Could you give us a summary of the participants that were included in the study?
So for the WAVE study, as described, we're interested in looking at an adult patient with acute cancer-associated thrombosis. We define by patient need to be enrolled within 72 hours of starting any therapeutic dose of anticoagulation. Cancer really defined by the standard way of active cancer diagnosed or being treated within the past 6 months, or metastatic and non-curable cancer. And the type of VT we include, because we want to be as generalizable as possible. So we do try to include really almost all types of VT that you will see in cancer patients, including upper and lower extremity DVT, and that will include distal DVT as well, symptomatic or incidental PE. But if it's incidental, we do want them to be at least segmental or larger. We also include unusual site VT treated with the planned treatment of anticoagulants for at least 6 months. We have some standard exclusion criteria such as platelet count less than 50,000 and creatinine currents less than 30 that, active bleeding, those kind of standard to the thrombosis trial that you can refer to the manuscript. So just briefly describe our population. So we have total of 91 patient eventually including the primary analysis. The mean age is about 59, with the majority actually being male, about 65% is male. Majority are Caucasian, white Caucasian 95%. In our body weight, median body weight is actually about 107 kilo. And because keep in mind, these are the patients who, to be included, their weight needs to be at least 90 kilo, because we believe that's the really a research question, is whether we should change our dosing regimen beyond 90 kilos. So that's why the median is 107.5, and also a pretty big body mass index with a median of 36. And we found that the majority of the patient actually has GI and GU cancer. So I'm sorry, about 36% have GI cancer and 15% GU cancer. That's two biggest cohort of cancer type, which is actually retrospectively is probably not too surprising, as during the study conduct, which we can talk about more in detail later, that DOAC become more and more prevalently used in this population, and low heparin tends to be reserved for GI GU cancer that people are concerned about higher risk of bleeding. So that also reflect in our patient population. The majority patient, more than 80%, is receiving active cancer treatment at the time of enrollment. There are about 16% of patients who are on concurrent antiplatelet agent.
Okay, so let's talk about the results. What did you find regarding bleeding outcomes? And there was no comparator in the study, but how do these numbers compare to the non-obese cancer population treated with anticoagulation
Yeah.
in general?
Yeah, that's so interesting, right? And so altogether, we planned on including 150 patients, but as Dr. Wang was alluding to, we started enrollment in April of 2018, which is just 5 months after the Hokusai VT cancer study was published, showing that it was possible to use DOACs to treat cancer-associated thrombosis. And that was followed by similar studies using rivaroxaban and later apixaban, to the point that as the study was enrolling, we observed a shift, right, in the management of patients with cancer-associated thrombosis, with an increasing use of DOACs. And that's important to keep in mind. That likely explains, as Dr. Wang was saying, why we had such a predominance of the IgU cancer, because that kind of became the remaining indication of low molecular weight heparin when it comes to cancer-associated thrombosis. To the point that we had to stop enrollment in the study because we couldn't continue. Recruitment rate had become too slow. So we ended having 91 patients enrolled. Of them, 3 had a major bleed, and that corresponds to a major bleeding rate of 5%. And so you were asking, how does it compare to other studies? It's certainly slightly higher than what were seen in these DOAC trials that I was referring to before. But it's a bit hard to interpret, because again, this ends being the first study using low molecular weight heparin in a cohort of predominantly GI and GU cancer patients who we know have a higher risk of bleeding, right? So you could rightfully say, well, we feel that the risk of bleeding is a bit higher than what you should have observed. At the same time, we believe it's more like maybe a new baseline, so to speak, in terms of what's the current bleeding risk in this patient population these days.
Interesting. Okay, let's talk about thrombotic outcomes and mortality. What did you find there? And again, how do these numbers compare to what you would expect in the non-obese cancer population treated with anticoagulation?
I would say the recurrent VT rate is actually quite consistent with what we found in the prior randomized control trial in the relatively quote-unquote non-obese population. We have one patient who, out of the 91, developed recurrent VTE, which is a proximal upper extremity VT, so it's definitely a new site at the 30 days, and then that gives us a cumulative incidence of 1.2%, so it's quite consistent. In our 6-month recurrent VT rate is about 7.3%, which again is more consistent with the randomized control trial. As for mortality, 20 patients died within 6 months, so the correspondence between two mortality rate about 22%, which actually is slightly lower, I think, compared to if you look at a large randomized control trial recently, is more in the kind of 25 to 30% range, but still, I would say overall is quite in park with what we know from the randomized control trial.
Okay, great. And then in addition to clinical outcomes, you also looked at trough anti-10A levels to assess for bioaccumulation. What did you find with the anti-10A levels?
Yeah, so we wanted to make sure that, by using doses that would be higher than the monograph, we weren't submitting patients to bioaccumulation of the drug, right? And so fortunately, like more than 80% of patients did undergo anti-10A testing. On average, things were looking good. Like after 7 days on treatment, the median levels were 0.2 and the interquartile range between 0.1 and 0.4. So only 25% of patients had a trough level that was higher than 0.4%. And it didn't show evidence of accumulation even after day 30. Levels were pretty much the same. Important to note, though, that we weren't actually sure, because when we quote trough levels, usually we mean at 24 hours after the last dose, just before the next one, right? What has happened in our study, because we were using doses that were higher than the largest pre-filled syringe, a significant proportion of patients were undergoing twice-a-day injection. We gave the choice. Like some patients might have chosen to get their 24,000 or 30,000 units on one shot, but others did prefer to switch that into two daily injections. And so then the trough became a 12-hour trough, for which we don't really have a reference range, because that's not something that had been done before using dalteparin. So no evidence of bioaccumulation, I would say, overall. That being said, when we looked at the anti-10A levels of those patients who bled as compared with patients without bleeding, we did see a correlation there. So that was interesting to see that patients who had a bleed had, on average, higher anti-10A levels at trough as compared with patients who did not bleed on low weight health.
I would just add a little bit that I think what's exciting it is maybe I'm biased, but what is exciting from the study that has not published out there is one is the twice daily trough level. Because when you look at the literature, it's already very limited, but the limited literature is really only on non-cancer population for so cancer population. We also don't really have a lot of data, and usually and also the data you have is actually usually when people use dalteparin to transit to warfarin. So they are usually on dalteparin for a very short period of time, 5 to 7 days, and they measure the level up to like 5 days, 7 days, and say it's all fine. So I think it's quite interesting that now we do provide a trough level at not only BID dosing, certainly we have once daily dosing as well, and we also have up to 30 days, and we're able to demonstrate that there's really no bioaccumulation.
Interesting stuff. So what are some of the limitations we should keep in mind when interpreting the study results?
Well, I can start. Certainly the main one is that the fact that we couldn't finish, right? So we didn't achieve our initial sample size. So certainly there might be some imprecision around our estimates. And again, I think the other one is that change. It was, it was performed right in the middle of the COVID pandemics and right in the middle of that shift between low molecular weight heparin for everyone with cancer-associated thrombosis, which was a situation in early 2018, to transition to a much larger proportion of patients getting low molecular.
Yeah, and I'll also add that you already mentioned, actually alluded to before, Jameel, that unfortunately it's a single arm study, so we don't have direct comparison. So we do try to compare to the previous study, but certainly recognize that it's a non-direct kind of in between study comparison. So I do think that we have to take caution for that kind of comparison. We also, we just mentioned, I think the trough level is quite interesting, but we did not get the peak level, which I think clinically some people might choose to do. The reason we choose the trough level is, again, we're trying to make study, also feasible from the patient standpoint. So it just become a little too much to ask this complex patient population who already have a lot of things going on to stay for both peak and trough. So we decided to choose just the trough. So then we really wouldn't be able to extrapolate to how the peak level will perform.
Okay, so let's talk a bit more about the dose capping. So the study suggests that weight-based dosing of dalteparin up to 33,000 units daily or in split doses is associated with an acceptable risk of bleeding and thrombosis. In the study, the dose was capped at dalteparin 33,000 units daily or split in 2 doses for those over 151 kilogram. And we only had one patient in the study who was over 150 kilograms at 180 kilogram. So we have limited data, but based on what we know now from the study, would you continue to cap the dose in those over 151 kilograms?
That's a good question. I think what the study shows is that at least between 100 and 150, you should likely not do that, right? Or so likely. I guess it's hard to say. I don't think I would cap myself, but certainly I would check anti-10A the way we did here, right? Just to make sure. We actually, I think, correct me if I'm wrong, Tzu-Fei, but I think in the study we tried to look at the extremes of body weight to see if there was a trend, but we couldn't really see. In other words, patients weighing more than 130 or 100 didn't seem to behave very differently. But
yeah, I agree.
I think I would keep increasing the dose, but certainly keeping an eye on the anti-10A.
Has the study changed your thoughts on if daily or BID dosing of dalteparin is preferred in those over 90 kilos?
I didn't really think about that. I don't think it changed my mind. I think it seems that it comes down to patients' preferences, right? I don't. Dr. Wang, would you have any?
I mean, I think the question probably came because we did find a nicotine trough is higher in the BID dosing, but I would highlight that I think we did do quite a few kind of background analysis, and our conclusion is that BID the trough level is slightly high, not really because of the dose is it's high. I think it's because, remember, we are measuring the trough right before the next dose. So the BID dosing, we're measuring the trough in 12 hours of the last dose as compared to daily dosing. We're measuring the trough, after 24 hours. So I think it's more the time difference rather than anything. Now, if we look at the bleeding outcome, I think that's what people really are interested, right? Like, whether the twice daily bleeds more than the once daily. I think I'll refer you to, we do have appendix that we, in the appendix, we did, listed our forest plot of subgroup analysis, and one of that is once daily versus twice daily. And certainly I recognize that the sample size is small, so the confidence interval is pretty wide. But the overall did not, I mean, yes, I can see that the numerically at 180 days potentially seem a little different, but overall we did not really find anything statistically significant for those. And I think the 30-day forest fire is in the actually the main manuscript that people can refer to as well.
Is there anything that we haven't discussed that you'd like to add?
This paper, we defined kind of obesity by body weight. We certainly recognize that has its own limitation, and there are recent data to show maybe other parameters would be better defined as body weight, such as body mass index, which again also has its own kind of criticism. But we can certainly, look, and I think certainly further study is needed to really look at this population, depending on the BMI or, to look at their outcome. That will certainly be of interest.
Another point that came up in the discussions with others is whether could you extrapolate that to every low molecular weight heparin? Hard to say for sure, right? The data, all this data is dalteparin here, so certainly a word of caution into extrapolating with others when pharmacodynamic properties might be a bit different.
Terrific. Well, thank you. And thank you both for joining us today and helping shed light on this important evidence. To our listeners, you'll find a link to the full publication in the show notes. And we always appreciate hearing from our listeners. And if you have comments, questions, or ideas for future episodes, please email us at info@thrombosiscanada.ca. If you want to stay up to date on the latest in thrombosis, be sure to follow or subscribe so you'll never miss an episode. And visit thrombosiscanada.ca for clinical tools, patient guides, and information on our upcoming programs. And before we close, I'd like to extend a special invitation. And if you value this podcast and the education we provide, please consider becoming a thrombosis champion with a monthly gift for as little as $10 a month. Your support helps us continue creating high-quality education content for healthcare professionals and patients across Canada. Thank you all for listening, and we'll see you next time on CLOT Conversations. And thank you both.
Thank you. Thank you for having us.
Thanks, guys.